Well, hello everyone, and welcome back to Human Biology here at Chaminade University. Today we will delve into the urinary system, which is Module 9A in your syllabus. So we're going to start by an overview of the urinary system where we talk about the general functions of the urinary system. So the urinary system works hand in hand with the circulatory system to regulate the concentration of waters and ions in your blood. It's also responsible for excreting the waste products of metabolism, which are going to then be filtered through the kidneys and excreted out through the urinary bladder. It's also responsible for helping regulate the blood pressure. So as the blood pressure gets too high, we can regulate it by changing the angiotensin-renin system. It's going to produce renin, which again that's part of that renin-angiotensin system that we'll talk about a little bit later on in this chapter. It's also going to help regulate the pH of your blood by excreting the excess hydrogen ions. So that's going to help. Remember, hydrogen ions are going to be the prime concentration of hydrogen ions, and the concentration of the hydroxide ions are basically what we're looking at when we're looking at pH, the relative concentration of those two molecules. And the kidney is also going to release several sets of hormones. So the hormones are going to be involved in circulating through the bloodstream and involved in many different things that are going to help your vitamin D stimulation, for example. So calcitriol is the active form of vitamin D that's going to be created, as well as erythropoietin, which is going to be something that creates red blood cells. So erythrocytes or erythrocytes. Erythrocytes are red blood cells. Poietin is going to be something that's stimulating. So poietin, anytime you see that, you're going to recognize that it's going to be creating something. So in this case, poietin is creating erythrocytes. So erythropoietin is a hormone that's going to stimulate the red blood cell production in the red bone marrow. Okay, so where are the kidneys located? The kidneys are a paired organ. We have one left and one right. They are not going to be located in the exact same section. They're just a little bit off, so they're like juxtaposed to each other a little bit. They're located right underneath the diaphragm. And here we have the region above them, which is the adrenal gland. So adrenal above the renal region. So it's going to be the adrenal gland, which is going to be responsible for secreting things like epinephrine, norepinephrine from the chromaffin cells. These are going to be the arteries that feed into it. So here we have the renal arteries and the renal veins returning. And then the ureters are going to descend out of the kidneys down into here's the urinary bladder, which is going to store the urine until we voluntarily excrete the urine through the process of micturition out the urethra. Okay, so again, the kidneys are responsible for interacting with the blood supply and regulating the composition of the blood as well as the volume of the blood. All of this is tied to blood pressure and blood pH. So it's going to regulate blood pressure and pH and also producing two of the major hormones we just talked about, namely calcitriol and erythropoietin. And it's also going to excrete any of the excess waste that are basically metabolic byproducts. Now, the ureters are long tubes that are going to come out of the kidneys and transport urine down into the urinary bladder. The urinary bladder is where we're going to store the urine, and when we expel the urine through voluntary discharge called micturition, we're going to expel it out through the urethra, which discharges the urine from the body. Okay, so where are the kidneys located? They're retroperitoneal, right? So that means that they're towards the back of the body, and they're going to be basically just towards the spine, so just in front of the spine. They're located between T12, or thoracic vertebrae 12, and lumbar vertebrae 3. And just to say, although they are paired organs, they're a little bit juxtaposed. So one of them is slightly lower than the other. The right kidney is slightly lower than the left side, just in case we end up with damage, right? So if we end up taking a good kick to one spot or the other, we might be able to save one if the other is damaged, which would end up saving that individual's life because we can survive with just the one if we need to. All right, so let's talk about the external anatomy of the kidney. So going from the outside in, we have the renal fascia, which is like a nice series of dense connective tissue. That's what holds the kidney to the abdominal wall. Remember, above the area we're going to have this adrenal gland, which sits just above the kidney. The renal capsule is going to be comprised of adipose tissue. So the capsule going to surround the whole thing. It's going to have a little bit of fat tissue in there. Then we're going to get to the cortex and the medulla, which is the very center part. This here is the hillux, which is where we're going to have the renal artery and the renal veins entering and exiting, also where the ureter is going to exit out. So this is where the urine is going to drain out into the urinary bladder. As we reach the internal anatomy, we just talked about, so here's the renal capsule, here's the renal cortex. Now I've got these renal columns, which are found in the renal medulla. So the renal medulla is going to have the renal columns, the renal pyramid. Sorry, the columns are found in between the pyramids. This is the renal pyramid. This is the renal column. And that's all going to be in the renal medulla. We also have these pelvis region, these multiple pelvises. These pelvises are where the liquid's going to drain and then out into the ureter. So the calyx is going to be the area where we're draining out. Here's the major calyx and the minor calyx, and they're all going to drain from the pelvis into the calyx out through the ureter. Okay, we also are going to talk about nephrons, which are a way that we can concentrate our urine. Okay, so the ureters are going to extend inferior medially. What does that mean? So inferior, lower, medially towards the center, and they're going to then exit out through the body through the ureteral openings. So the urinary bladder is able to compress. It's got some muscle tissue, so when it compresses down with the detrusor muscle, it's the actual active micturition is going to compress this urinary bladder. We also have sphincters, so we have an internal and external urethral sphincters that allow us to choose when to urinate, or that gives us voluntary control. And what's interesting about the urinary bladder is that it doesn't have any backflow. It prevents backflow by compressing the ureters when it becomes full. So that's going to cause a pressure inside there that's going to kind of cause them to kink off so that the water doesn't, or the urine doesn't flow backwards. So when the pressure builds up in the bladder, we're not going to end up with any backflow of urine into the kidneys. So this is an external orifice of male and females. Okay, so female will have a much smaller urethral opening. Male will obviously have a longer urethral opening because you have to extend the entire length of the penis as well. The urethral opening in the male is also going to go right on past the prostate gland. It's also a shared ureteral opening, so it's also going to be part of the ejaculatory canal. So it's the reproductive canal as well as the urethral canal, which is where the prostate gland would be secreting during the process of ejaculation. Another accessory sex gland here is the bulbourethral glands, also going to be secreting fluid during the process of ejaculation. But the point that I'm making here for micturition or urination is the fact that we have to go through a very long pathway, and we have several different sections of this ureteral opening. Okay, the wall of the ureter has three major layers. We have a mucosal layer, a smooth muscle layer, and then a connective tissue layer. All right, so here we are going to have, again, the mucosal layer, the smooth muscle, and then the connective tissue. So here's the connective tissue. The center part is the mucosal, and then this part here is smooth muscle. All right, so the layers of the bladder wall. Again, we have the inner mucosal layer that's shown here in this light pink line. That's going to have transitional epithelium, so it's going to be an epithelial layer that's going to transition from one cell type to another. And also is going to have rugae, which we've seen previously in the stomach. So these folds or rugae allow for expansion, so it can get larger when it's going to be under pressure. That middle layer is muscular. So we have three layers of muscle. We have the Detruder Muscle, basically, and what this going to do is going to allow us to contract this down so that when we urinate, we can expel the entirety of the urine. So we don't just use gravity. It's not just a gravity-fed system. We actually are going to squeeze down and contract. On the outer layer, we have the superior surface, which is a peritoneum region here, and then the remaining surface is covered by a nice fibrous coating. So we have a serous membrane. Again, the peritoneum is a serous membrane, and the rest of it is fibrous. Now, as I mentioned, we have two urethral sphincters. The internal urethral sphincter we are not in control of. It's under involuntary control. What does that mean? That means that when pressure builds up a lot, it's going to open up that internal sphincter. That gives you the urge to urinate. But you still have time to find a bathroom, which gives you the ability to have voluntary control. And that's due to this external urethral sphincter, which you are able to voluntarily control. It's got skeletal muscle, and you actually have to pinch it down when you really have to urinate, right? Again, here's the ureteral openings that will end up being pinched off to prevent backflow. So the ureteral openings end up with pressure on them. That's actually going to pinch. You can't quite see, but it's going to pinch off the ureter in the back so that nothing's going to go straight on through. Okay. So I told you we were going to get to nephrons. Nephrons are a specialty unit of the kidney. We have 1 million of them in each kidney, and they're structurally and functionally designed to be able to concentrate your urine. So the nephron consists of two different regions, the glomerulus, which is a whole bunch of capillaries, basically, and that's where we're actually going to be filtering the blood out, and excess waste is then going to travel out here, and that's going to go into the Bowman's capsule, which is surrounding the glomerulus, and then this long tubule is going to become the nephron. So basically what happens is we're going to have a filtration event where basically fluid is going to move out of the glomerular capillaries here and into the Bowman's capsule. And then we're going to resorb back anything that we want to keep. This is the equivalent of a woman taking her purse and dumping everything on the counter, picking up her cell phone, her car keys, and her wallet, putting it back in her purse and leaving everything else on the counter, right? All the waste. So that's what happens here. We push everything out, and then we pull back what we want. And when we resorb things back in, those are the things that we're going to be utilizing, things like sugars and proteins, things that should not be making it through to your urine. Everything else is going to be secreted out, and that's going to end up going into the peritubular capillaries and going through this whole nephron tubule. We also have excretion, and that's going to be when fluid moves from the nephron tubules into the bladder to outside of the body, right? So that's going to be the actual action of excreting the liquid out of the body, right? So again, we're having from the nephron tubules out here, out into the bladder, which then goes into the excretion through the ureter. Okay, so this all comes into it's basic math, right? The amount of substance excreted is going to be the amount filtered minus the amount resorbed plus the amount secreted. So everything that goes out minus the amount that we take back plus everything that we add to it, right? So that's how much we're going to excrete. All right, so here's our application question. And it's talking about a runner, a marathon runner named Bert, who's hoping to finish a half marathon in 2 hours. And we do know that his cardiac output is going to increase. It will actually double probably throughout that 2 hours. And if a normal cardiac output is 5 liters per minute, and his blood pressure will be increased, and it tells you from what to what, how will the increase in cardiac output and blood pressure increase the filtration rate? Will the filtration rate increase or decrease? And how will exercise affect glomerular filtration rate? Will it increase or decrease? And what is it that you think Bert could do before the race to try to decrease any fluid loss? Okay, so we'll let that simmer for a bit, and we'll come back to that at the end of the chapter. All right, so let's talk about the nephron for a second. So a nephron is going to have multiple sets of capillaries. We have the glomerular capillaries, which are going to be part of this glomerular apparatus, which is surrounded by the Bowman's capsule. And we have the peritubular capillaries. Now, the glomerular capillaries have little slits in them. So there's podocytes. Podocytes have little pedicels, little holes in them. And basically, that's going to allow for filtration. So these are fed and drained specifically by an arteriole, both afferent and efferent. It's the only time in the body that we see arteries not only carrying blood to, but also carrying blood away from. So in this case, what we're doing is we're just filtering the blood out. We're not delivering anything to it. We're not dropping off oxygen, which is what most of the blood supply would take it from the arteries to become veins, right? Venous return has less oxygen to it. All we're doing here is we're filtering things out. We're dumping everything on the table and picking back up what we want. Okay, so again, we have specialty cells here called podocytes that have little filtration slits that allow liquid to come out of the blood supply. That's called filtrate. And then some of the filtrate goes back, but a lot of it's going to go out. So that's going to give us a net filtrate of leaving, right? Okay, so basically we end up with blood pressure in the capillary forces that starts off really high, so we're forcing all the fluid and solute out into the glomerular capsule. And then a good bit of that is going to be resorbed back up, right? When we dump all our stuff out of our purse, we're going to pick back up our cell phone and our wallet and our car keys, anything that we think that we need. So that would be like our proteins and our sugars, etc. So a lot of it's going to be resorbed and returned back into the blood through the peritubular capillaries. However, some of the filtrate is going to migrate on. We also have specialty cells here that are called Juxtaglomerular cells, and that's these guys here shown in blue. They're specialty smooth muscle cells that are able to secrete special granules that are going to have renin, and renin is part of the renin-angiotensin system, which helps regulate blood pressure. And these guys are what we call mechanoreceptors. That means that they're able to sense blood pressure in what's called the afferent arteriole, or the artery that's leaving the glomerulus. So they're going to detect blood pressure and then utilize that information to be able to help regulate blood pressure. Okay, we also have a region called the Macula Densa. These are going to be tall, closely packed cells. They're here. They're shown in pink here. They're going to be sitting just next to the juxtaglomerular cells. Okay, so just adjacent to the granular juxtaglomerular cells. And these guys have specialty receptors that are called chemoreceptors. Now, chemoreceptors are chemical receptors, and they detect, they're specific to the chemical that they detect, but these chemoreceptors are going to detect sodium chloride or salt in the filtrate. And they're going to work hand in hand. So these cells here, the macula densa and the juxtaglomerular cells, work hand in hand to control blood pressure by being able to also control the solute concentration of salts, okay? And so how do we do this? So if we decrease the salt concentration as detected by the chemoreceptors in that macula densa region, okay, these guys are going to signal two different things to the arterioles and to the juxtaglomerular cells. So in the arterioles, we're going to decrease the glomerular filtration rate, so we're going to have less blood flow through the glomerulus, and the juxtaglomerular cells are going to increase their production of renin. Okay, and we'll talk about the renin-angiotensin system in just a minute, I swear. So the rate of glomerular filtration is going to be dependent on multiple different sets of pressures, right? So here we have the pressure that's going to be going out. That's the hydrostatic pressure in the capillaries, pressure forcing outward. We also have hydrostatic pressure in the Bowman's capsule, as well as what we call osmotic pressure or osmotic pull of water in the glomerular capillaries. So we have out as well as in and in. And the sum of all of this is going to determine what our net filtration rate is. So all these different hydrostatic forces are basically forcing fluids and solutes across the membrane one direction or the other. And this allows us to basically filter out what we don't want and pick back up what we do because of these different inverse pressure systems. It also means we have a very large surface area because of all of these different pedicels, right? It's going through a lot of different surface area here, so it's going to be very permeable to water and solutes. And because the glomerular pressure out is typically higher than the pressure in, the glomeruli are going to produce about 180 liters a day of liquid, whereas other capillary beds are only going to produce 3 to 4 liters a day. Now, that doesn't mean you're going to urinate out 180 liters a day, right? You lose all your fluid. That means that this pressure is equivalent to filtering ascending across 180 liters a day, right? But we're also going to be resorbing that. So that's putting pressure outward, but we have a lot of pressure also coming back inward as well. All right, so what's the point of this whole thing, right? The filtration is set up so that we can use osmotic pressure to regulate our blood pressure and the concentration of our salt while simultaneously eliminating any of the toxins or molecules that have built up in our system because of our metabolic pathways. So in order to do this, we have to maintain specific osmotic pressure or pull of water across the membrane. So the plasma membrane proteins are really important because the plasma proteins have to stay inside the blood supply. So we have to make sure that the protein actually stays inside. So although the protein might at this stage go across, it's always going to be picked back up. So when I said the lady dumps her wallet or everything in her purse out, she's always going to pick back up her wallet, her cell phone, and her car keys, okay? Always going to pick back up our plasma proteins as well as our sugars. Okay, so if we find that in the urine we have protein or blood cells, so we're always supposed to pick up our blood cells, our protein, and our sugars. If we have blood cells or protein, that's called proteinuria, and that means that there's something going wrong in your filtration mechanism. This is an early sign of things like diabetes or hypertension or kidney damage, and if this ends up untreated with like dialysis or etc., the condition can progress until we end up in full-on renal failure. All right, so as I mentioned, we're pushing things out, and then we're resorbing things back in. So certain things are going to come back into the bloodstream. Nutrients, ions, and water are all going to come back into the bloodstream in the peritubular, the capillaries. So this is talking about things that are going to be resorbed and in the different regions. So in the proximal tubule, we're going to be resorbing water, glucose, amino acids, right? They provide proteins, or they are going to comprise of the proteins. Sodium and potassium, bicarbonate, chloride, calcium, magnesium, urea, vitamins, lactate. These are all resorbed in the proximal tubule. And in other regions of the nephron, we're also going to be resorbing things like water, ions, bicarbonate, sodium chloride, water, and urea. So we're bringing certain things back into the body from what we've already put out on the table. So immediately we're going to grab our cell phone, keys, and wallet, but we might also decide that we need that keychain, that stick of gum, and this pen, right? So there are other things that we're always going to be pulling back. However, some things are just plain waste, right? Metabolic waste. And so we want to make sure that we're excreting the metabolic waste while retaining what we want to utilize for our body. All right, so the first goal is secretion. That's the dumping the purse on the table, right? So we're going to be transporting waste, creatine, hydrogen atoms, potassium atoms, etc., into the tubule, right? This is all being dumped out of the purse. And we're going to regulate our blood pH by regulating the concentration of our hydrogen ions. So sometimes we're going to be pulling hydrogen ions in if we have a pH that's gotten too high, and sometimes we're going to be excreting hydrogen ions if we've got a pH that's too low. So we're going to utilize the excretion of hydrogen ions to help regulate our blood pH, which is in direct concentration or direct correlation with the respiratory system. Remember, the respiratory system is going to be bringing in oxygen, off-gassing carbon dioxide. And if we have too much carbon dioxide in our system, we can end up with acidosis in the blood. So the respiratory system works hand in hand with the kidneys to help regulate the blood pH. We must have a really stable blood pH, approximately 7.4 into the arterial blood. And we also are going to create something called creatinine. Creatinine phosphate is used as an energy source when we use muscle cells rapidly. We're going to use it to reload our ATP. And so creatinine is a waste product that's produced when creatine phosphate is utilized by the muscles. So it's going to be excreted as well. Now, when we're breaking down proteins, we can create ammonia. Remember, we're going to have on the edges here, we have the NH2, that's an amino group, carboxylic acid group. But when we break that down, this amino group can become ammonia very easily. And ammonia is toxic, so we're going to change it to urea almost immediately because ammonia, again, is really alkaline. So it's the opposite of acidic, or it's going to be a high pH, and it's highly toxic. So we're going to get rid of it as quickly as possible. Again, by converting it to urea. Other things that are converted to urea are anything that's a pyrimidine. But sometimes things like purines, which are going to be things like adenine and guanine, those are all going to be converted into uric acid. So we're either going to convert things into urea or uric acid and hopefully excrete it out of the body, because if we have too much uric acid inside the body, we can end up with kidney stones, which don't excrete on their own unless well, the smaller ones I suppose do. But oftentimes they'll have to sonicate or use some medication to help decrease the size of the kidney stones. And we can also end up with what's called gout. So gout is when excess uric acid builds up inside the joints, typically in like the feet. And it's extremely painful and can make it that people are wheelchair bound. There's a lot of medicine these days that we can utilize to help offset the excess uric acid in the body to alleviate people who are suffering from gout and kidney stones. Okay. So as I mentioned, we're dumping everything out on the table, but we're resorbing a lot back. So everything that's going back into the purse is going to be resorbed. We can resorb it either in the proximal tubule and other regions of the nephron. But the things that are going to be resorbed all the time, glucose, blood cells, amino acids, okay, these should not end up in the urine. And the resorption can happen in a couple different ways. It can happen by facilitated transport or via the process of diffusion. Now, we have two different regions. When we're looking at the membranes, we have one region that's going to be the apex or the apical side, and the other side is going to be the basal side or the basolateral side, which is going to be the area that the capillary bed is going to be by. Sorry, this is the basolateral side. Here's the apical side. So again, the basal side is going to be right next to the capillary bed. And so we're going to be able to have exchange between these cells, including paracellular and transcellular flow. All right, so as I mentioned, we're able to transport things across the membrane, things like sugars, etc. So we're able to maximize the resorption of glucose and protein, etc. And if we find glucose in the urine, we might have a problem with something like diabetes, for example. So if we have diabetes that is untreated, these patients will excrete glucose in their urine, which is abnormal, and also excrete more water in their urine. Now, normal blood glucose is going to be somewhere around 150 milligrams per milliliter, but type 2 diabetics are going to have excess glucose in their blood because their cells aren't able to take up the glucose. Remember, we use glucose to make ATP. And so if they're unable to take up the glucose, then it's going to end up in their blood supply. And also they're going to end up, as a side note, they'll be lethargic because they don't have the ability to convert the sugar into ATP. And we use ATP for cellular energy. So if we don't have cellular energy, we're not going to feel very well. They're also going to end up excessively thirsty because they're excreting a lot of water, which means that their body is going to be dehydrated. So let's talk about resorption. Normal resorption is going to be occurring in the proximal tubule and in the loop of Henle. Almost all of that resorption occurs in those regions. And we have extensive resorption in that region to make sure that solutes are going to be able to come on in and the volume of water entering the tubular segments are relatively small. Now, the distal segments are going to be the fine tubing. So those early segments are just going to be mass flow, and the distal segments are going to allow determining the final amounts of XYZ excreted in the urine by adjusting things like rates of resorption, and if we have too much in the body, secretion of something that we should not have resorbed in the first place. So we can increase or decrease our rate of resorption, or we can secrete something that we have too much of and we need to edit. So how do we do all of this? How do we regulate the water concentration? Well, water follows salt. So first, the sodium resorption occurs, and this is an active process in most places. And then the water follows. Then the water resorption is going to follow immediately by diffusion. And again, it's dependent on sodium resorption. So wherever the sodium goes, the water will follow after. Water follows the sodium through what's called Aquaporin Channels. Now, sodium doesn't go through those. Aquaporins are specific for water. And we have a different amount of aquaporins as we go through the different tubule sections. So they're going to have a lot of these aquaporin channels in the proximal nephron and almost none in the collecting ducts. Now, this is going to be regulated by something called Antidiuretic Hormone, or ADH. Anything that is a diuretic is going to cause you to urinate. So coffee, for example, is a diuretic. Diuretic simply means it's going to make you excrete excess urine. And antidiuretic means that you're going to be conserving the water instead of secreting the water in your urine, so it's going to concentrate your urine. So when ADH is active, it can actually change the expression of the aquaporins in the different regions. Okay, so cation means that it's positively charged. Anion means that it's negatively charged. Think like anti, or can is positive, right? So cation is going to be a positive charge. And sodium is the most abundant cation that we're going to find in this urinary filtrate. And then we're going to resorb that sodium through sodium channels. And utilizing sodium-potassium pumps, which are going to be regulated by ATP, so it's going to need ATP to occur, that's going to create what we call electrochemical gradients. So a gradient is going to be when we have different concentrations on one side of the membrane or the other. And when we have an electrochemical gradient, that means that we're going to allow things to enter, other substances like glucose, etc., down this concentration gradient via transporters. So this slide talks about the regulation of the urinary system and the different hormones that are involved in the regulation of the urinary system. And we just talked about ADH, or antidiuretic hormone, so it's going to be involved in water retention. So it increases water resorption by producing aquaporin membrane proteins in the distal tubule and the collecting ducts. Aldosterone is going to be a result of increased angiotensin 2. It's going to increase sodium resorption, which therefore increases water resorption, and also increases the secretion of potassium. All right, so parathyroid hormone produced by the parathyroid gland is going to increase the resorption of magnesium and calcium. And atrial natriuretic peptide, which is found in the atria of the heart, is going to do the opposite of ADH and aldosterone, namely it's going to result in the excretion of water instead of the resorption of water by decreasing the amount of sodium that is resorbed across the membrane. Okay, so let's talk about the thirst response. When you're thirsty, you've already lost approximately 1% of your body weight in water, and your body is trying to regain that water to help make sure your metabolism is going well, right? We need water for all of our metabolic pathways, right? For our synthesis reactions and our dehydration synthesis reactions, and for our hydrolysis reactions. And so if we are low in water, what probably is happening is that we're going to end up with a change in our blood pressure, right? And also a change in our blood viscosity, as well as our change in our sodium concentration, all right? So all of this is going to lead to a decrease, lead to renin being expressed in the let's just say glomerula, not juxtaglomerular, that should be a G, so that's a typo. And the juxtaglomerular cells, when that's going to convert angiotensin, which is found in the liver, into angiotensin 1. So angiotensin to angiotensin 1 is going to be converted by renin. Now angiotensin 1 to angiotensin 2 is going to be converted by what's called ACE, angiotensin converting enzyme, in the renal epithelial layer. And so that's going to then act. So this is going to be a precursor to an actor. So angiotensin 1 gets converted to angiotensin 2, angiotensin to angiotensin 1, angiotensin 2. Angiotensin 2 is going to lead to the production of aldosterone by the adrenal cortex, vasoconstriction of our arterioles, right? Increased water and sodium resorption in the body, which is important because we want to make sure we're keeping as much water as possible if we don't know when we're going to get our next bit of water. Increased potassium excretion. This is kind of a byproduct of that sodium-potassium pump. So in order to resorb sodium, we're going to be pumping potassium out. And in the pituitary gland, we're going to be secreting antidiuretic hormone. All of this is going to trigger the thirst response, right? Which hopefully we're going to then drink something. But it's also going to lead to the fact that we're going to be resorbing water in the collecting ducts. So instead of excreting more water, we're going to be concentrating the urine and collecting most of that water back into the body. So this angiotensin-renin system is going to be a part of regulating your thirst response as well as your blood pressure and your blood viscosity, etc. So that also regulates your water concentrations, your ion concentrations in your blood, etc. Okay, as I mentioned, a diuretic is anything that's going to promote the loss of water in the system. And any time that we're having the loss of water, remember water follows sodium, so that means first we're going to have the loss of sodium. So diuretic is going to promote the loss of salt and water. So things like alcohol and caffeine, for example, are going to inhibit the release of antidiuretic hormone. So if we're inhibiting the antidiuretic, we are going to end up with a diuretic response. Diuretic medications are going to basically work because they inhibit the formation of a gradient. Remember, we talked about the gradient being how we're going to concentrate the urine, which is going to lead to less water being resorbed, meaning that we're going to have more water excreted. We also have angiotensin 2 receptor blockers. So these are going to block, obviously, the receptor for angiotensin 2, which inhibits the production of aldosterone and therefore also leads to the excretion of water. Now, in certain individuals, the kidneys can start to fail. And before we get full-on failure, we're going to have chronic kidney disease, which is a disorder where we're leading to kidney failure, but we're not there yet. And typically this is going to be caused by a combination of hypertension and or diabetes. And chronic kidney disease is typically characterized by a gradual loss of kidney function. So it's not going to be an overnight decline, but it's not typically going to get better either. We don't usually end up seeing restoration of function. So kidney function is determined by the glomerular filtration rate. How much of your blood is filtered out through the glomerulus per minute, per hour, per day, etc. And as the disease progresses, the filtration rate decreases. So less and less blood is filtered out through the kidney. And that means that we're not going to be able to remove all of our metabolic waste. We can also determine the amount that our kidneys are functioning, so the percentage kidney function, by looking for something called albumin in the urine. Now, albumin is a protein. Remember, proteins are not supposed to be present in the urine. Things like proteins, red blood cells, and glucose are the equivalent of your car keys, wallet, and cell phone. They need to go back into the purse, right? So if the urine has protein in it, the kidneys are not working functionally. So we have damage to the kidneys, and we can indicate how far that damage has progressed by how much protein is found. And typically, as we're starting to see failure of the kidneys, we're going to start seeing several other symptoms as well, including nausea. They'll get very weak and frail, fatigue, lack of concentration capabilities. So there will be a mental fog. They'll start feeling lack of appetite, which is also associated with nausea, sometimes cramping because the ions aren't regulated properly. Remember, they say, if you have a cramp, you should eat a banana, right? Because the bananas are going to help restore the potassium. So the ion regulation comes to that sodium-potassium pump. If we're having dysregulation there, we might end up with a loss of potassium, etc. Can also lead to increased blood pressure and swelling or edema in the tissues. Typically, this happens most commonly in the feet because that's where things drain towards, is downward, right? And all this happens because of a decline in their ability to control their blood pressure, which are all going to be regulated by the kidneys. And once we get to the point where kidney failure occurs, at this point, the treatment is constant dialysis until we can find a kidney transplant. So make sure that you protect and take care of your kidneys. All right, so these are some examples of kidney stones. Kidney stones are an abnormality that affect about 10% of the population because of excessive uric acid or perhaps the production of something called calcium oxalate. And basically what happens is the uric acid is going to build up. It's a waste product that happens when we break down purines, and it can happen either in the kidneys or in the joints. If it happens in the joints, it's called gout. It's extremely painful because it can be sharp, right? See, these stones can be calcified or kind of sharp. And uric acid inside the kidneys causes kidney stones, right? So this is going to be a genetic disease, a genetic disorder that's linked to a metabolic syndrome whereby you are decaying your purines more quickly than normal, so you end up with excess uric acid. So again, it's typically going to be something that is genetically linked, so if your parents have it, you might want to keep an eye out for it. And symptoms of kidney stones are going to vary, depend on the size of the stone. So some stones are very small, some of them can be very, very large. They are said to be extremely painful, and that the pain can radiate out from the lower back, which is where your kidneys are going to be located, right in front of the spine, towards the front in the abdominal area, the groin area, depending on which part we're going to have the stones in there. It can cause blood in the urine, as you can see, because it'd be cutting into the kidneys. It can also cause nausea or fever because you have an inflammatory response anytime you have something going wrong, and also extremely painful urination. Oftentimes the small stones will pass without treatment, although it can take several days and can be extraordinarily painful. Large stones can often be treated with either surgery or something called sonication, where they put high frequency sound waves that are going to sonicate, shake, and then break up the stones. Okay, so as we get older, our tissue function is going to decrease. We're going to end up with smaller kidneys, so the actual tissue size is going to decrease, as well as the number of nephrons are going to decrease. So we're going to end up with a decrease in the filtration rate, the resorption rate, the secretion. So all of this is going to become less efficient. And if they also are compounded with other disorders like atherosclerosis, for example, atherosclerotic plaques are going to be when we're going to be inhibiting or squeezing off the blood vessels because we have plaques on the inside, so we have smaller and smaller diameter for blood to flow through. So that combined with the age is going to have a decreased blood flow to the kidneys. So individuals who have atherosclerosis are going to have less blood in general flowing through, and that means they're going to have a less filtration. And as we get older, we might end up with urinary incontinence because of the loss of elasticity in the bladder. So we may need to go to the bathroom more and more frequently, or may end up with their inability to hold their urine, so have the urine just kind of seep out because of the inability to control the internal and external sphincters the way they used to. So, okay, this brings us to the application question. So when Bert is running the half marathon, that will cause his blood pressure to increase. An increase in blood pressure causes an increase in GFR, or glomerular filtration rate. And we also are simultaneously going to see an increase in cardiac output. So an increased cardiac output is going to cause an increase in blood volume. So more blood volume is going to mean more blood circulating through the kidneys, also increasing the GFR. So this increase in filtration is going to cause an increase in urine outputs. However, it's going to also see a loss of water through sweating. So overall, he's going to have a loss of blood volume because of fluid loss throughout the body. So as that happens, his kidneys are going to regulate the blood volume accordingly. So as we start losing water through sweating, we're going to retain more water in the kidneys. So if Bert wants to try to retain fluid to prevent excess water, he could either take less water throughout the run by taking a salt pill, or he can increase the amount of water that he drinks through the run. Because remember, if you take a salt pill, sodium is going to increase the body's ability to retain water, then help keep the blood osmolarity stable. So we're going to take the salt pill, that's going to increase the sodium in the blood, going to increase the retention of water, so we're not going to urinate as often, meaning he doesn't have to drink as much water throughout his marathon. All right, everyone, thank you so very much for coming to class today. I really appreciate you. Happy studying and have a great day.